Ladies and gentlemen, it is a great pleasure for me to introduce the first keynote speaker, Professor Lord Darcy of Denham, Professor of Surgery, Imperial College London, the UK. I might say that we are friends for quite a while, and it's my great pleasure to see him again in Hong Kong. And of course, Dr. Tracy Cooper, who is immediate past president of the International Society for Quality in Healthcare, Ireland. We will be doing what would you call that? A live streaming of the whole lecture. So I will say something about Lord Darcy first, and then you can carry on from there. Professor Darcy holds the Paul Hamlin Chair of Surgery at the Imperial College London, the Royal Marsden Hospital, and the Institute of Cancer Research. He is director of the Institute of Global Health Innovation at Imperial College London and an honorary consultant surgeon at the Imperial College Hospital NHS Trust. Research led by Professor Darcy is directed towards achieving best surgical practice through innovation in surgery and enhancing patient safety and the quality of health care. He has contributions within these research fields and has been outstanding, publishing over 800 peer-reviewed research papers to date. In recognition of his achievements in the research and development of surgical technologies, he has been elected an honorary fellow of the Royal Academy of Engineering, a fellow of the Academy of Medical Sciences, and most importantly, a fellow of the Royal Society. He was knighted for his services in medicine and surgery in 2002. In 2007, he was introduced to the United Kingdom's House of Lords as Professor the Lord Darcy of Denham and appointed Parliamentary Under-Secretary of State at the Department of Health. Upon relinquishing this role, I think he had enough of government policy, perhaps, within central government in 2009. He sat as the United Kingdom's Global Ambassador for Health and Life Sciences until March of last year. During this appointment and beyond, Professor Darcy has developed his status as a leading voice in the field of global health policy and innovation. In September last year, Lord Darcy was appointed to lead a new clinically led London Health Commission, which will conduct an evidence-based investigation into healthcare provision and resources for Londoners. That's an interesting job. Professor Darcy was appointed and remains a member of Her Majesty the Queen's Most Honourable Privy Council since 2009. Here, his lecture title today is a very important one, and it's about innovation in patient safety. I'll hand over the mic to Dr. Cooper now.
Thank you, Professor Lung, and good morning, ladies and gentlemen. On behalf of ISQua, which is the International Society for Quality in Healthcare, I'm delighted to introduce our inaugural Global Leaders Lecture, and we're very delighted that Lord Darcy has agreed to deliver it. I'd also like to welcome our many hundreds of friends and colleagues around the world who are joining us now as we speak, as we live stream our lecture. In ISQua, we were here in 2011 for a large international conference, and we worked very closely with our friends in the Hospital Authority. And with all of the progress that's happening in Hong Kong, it seems very fitting that we're launching a significant Global Leaders Lecture out of the Hospital Authority's convention. And many thanks to Professor Lung and Dr. Lung for enabling us to do this. As I say, we're absolutely delighted that Lord Darcy is delivering this first most important lecture. Lord Darcy, as Professor Lung has already introduced, has made a significant impact on improving quality and safety in many countries around the world, and I'm sure that there are thousands of patients today who have benefited in their outcome and their experience from Lord Darcy's personal contribution. So please join me in welcoming Lord Darcy.
Thank you, Chairman. It was lovely to see you, John, leading the health authorities here, and it's a great privilege to be here with many, many friends and colleagues. Also, it's a great privilege to be delivering the ISQua lecture, so thanks for that, Tracy. I wanted to share with you my own thoughts where we are in this very important area of patient safety. I think history will suggest that many of us in this room, most of our work to date has been epidemiological one. It's been about the prevalence of errors and harm in health systems. And I think most of us now have come to the conclusion that we work probably in the most unsafe system within the context of innovation and technology that over the last century has doubled life expectancy. And that's the paradox. On one hand, we've doubled the life expectancy of mankind, and no other sector could beat us on that, but we're also working in the most unsafe system. And that prevalence rate, it depends what you read and what you look at. It ranges anywhere from 5 to 10%, and from my perspective, it's about 10%. It depends the way you measure it. Probably if you're doing case note reviews, you're going to get a more accurate measurement. I think it's also important to differentiate between what we call an error and what is an error that leads to harm. I promise you, I probably have made half a dozen errors since I woke up this morning in many ways, whether that is my social skills, whether that was what I did when I checked into the hotel. But I very much hope that none of these errors led to any harm to anyone, and certainly I'm still standing here giving this talk. So what's important to realize and focus on is which of these errors that are leading to harm that we could do something about. And I think research in this area, believe it or not, is not that sound. If you really look at recent publication we had, which was a systematic review looking at how we reduce the burden of harm in surgical patients, you will come across about 26,000 publications. That's a huge, huge number of publications. But out of which there's only 17 that are evidence-based interventions in which could contribute to policy, and that policy may have an impact in reducing harm. So the first message, this area is still not fully understood, and we can sit down and translate and learn from other sectors to a degree, but ultimately there's a significant amount of work that needs to be done within the health systems to understand how we come up with innovations, how do we come up with evidence-based interventions that will challenge this. And I think some of us, as we've heard from some of the significant media interest in this, that continuing the way we are is not an option. And today's talk, I'm going to share with you some thoughts, some ideas still in progress, something about data and the use of such data in trying to tackle this issue, which is not only costing the healthcare system a significant amount of money, but let's not forget the physical, the psychological, and the social trauma to the patients we treat. And a lot of work has gone into the governance of different organizations, different providers, new tools, new techniques, new innovations. Some of the national interventions that we've been involved in the UK, certainly a country who's had a fairly interesting history when it comes to patient safety. And my specific interest in this started after the Bristol inquiry, which was very much based on a surgical issue, and what we've learned since then, and more recently, another inquiry, which was the mid-staff. So if I could start firstly with tools and interventions. And I think there are some evidence-based interventions there, one of which is the surgical checklist and its introduction, and certainly the leadership that WHO has worked through back in 2007 and 8. This was an interesting piece because I remember as an academic being involved with this and with Atul Gawande at the time in 2007 and 8. And when I joined, and I had the privilege of being in office, we drove this through our National Patient Safety Agency to make it mandatory that every organization should be using the surgical checklist. Now, I have no doubt it's no different in Hong Kong. The data is there, 19 evidence-based indicators. May I just say the evidence base underpinning these has been around for more than a decade. We know these interventions work, and this was the study which was published in the New England Journal of Medicine, looking at the baseline versus organizations that have implemented the checklist, and you can see the dramatic reduction in harm to and errors to our patients. But subsequent to that study, we also did a fairly large national study funded by NIHR on the implementation of the checklist once it became mandatory in the UK. And the results were quite disturbing. And that is the actual adoption, the actual accurately getting that checklist filled in rather than a tick-the-box exercise, which we've noticed in about 8 different organizations looking at 5,000 patients. And you can see different areas of the checklist uncovered or not even utilized. And in many ways, it brings you back to this thought, and I'll share this thought with you when it comes to patient safety. How do we improve it? How do we drive it? How do we really get the adoption and the diffusion once we have that knowledge base? And historically, we've done different things in different ways. We can use regulation. We can use legislation. And I could promise you I have taken more and more bills. 2 years being a minister, I've taken 3 different health bills with all sorts of legislative inputs. Sadly, you introduce any form of an intervention like the checklist, as you can see, the adoption is less than satisfactory. So I'm going to share with you one of my thoughts of how do we change the culture? How do we actually change the behaviors of the clinicians working within the health system? And I just wonder how many of you in this room have seen, well, I suspect half of the audience probably haven't seen this. The other half probably have. And this all started in an airport. And started in an airport in Holland for the simple reason is cleaning the urinals was a significant challenge. And the ability to put the little fly and exploiting the competitive nature of a male, you reduce the incidence of spillage significantly. And in many ways, that is what we need to do within any organization delivering healthcare in making safety the norm. And this has become a science in itself called behavioral economics, and certainly in recent times, we were actively involved with the Cabinet Office, publishing something called the Mindspace, which is, these are the acronyms for what the Mindspace stands for. And I'll give you some examples which are relevant from a healthcare perspective. Firstly, who is the messenger? I know the health authority here is very well trusted, but if you come to the UK, the messenger plays an extremely important role as far as the adoption. We know for a fact if the messenger happens to be, in relation to clinical guidelines, happens to be a professional association, the uptake of that is significantly greater than the messenger being the government. Depends on the norms. What are the norms in a healthcare system? We've seen more and more of that in certain behaviors like alcohol and binge drinking. I'll give you some other ones. Priming. We know now with clear evidence that changing the smell in a ward will transform the behaviors of those who work in the ward as far as the cleanliness of a ward and washing your hands. And I'm not suggesting this is the be-all and the end-all. What I'm saying is to get the balance right between a regulatory framework and some interventions will make that change happen. Designing bugs out, and I know there are many people from the UK here who are actively involved in this. This is the era of the significant challenge of hospital-acquired infections, MRSA, bacteremia, and also Clostridium difficile. And the challenges that face the health service, beside the burden on our patients, was it was costing the health service about 1% of our budget. We were spending £1 billion a year on managing patients with hospital-acquired infections. And all sorts of interventions came in, one of which was also working in partnership with the Design Council. How do we bring designers into the health systems to help us redesign elements of a ward, of a patient, of a trolley in trying to reduce these different challenges of cross-infection? That doesn't in any way take away the behavioral change that is required if you're going to wash your hands as a doctor or a nurse. And you can, at a national level, and something we're very proud of in the UK, a dramatic reduction in the hospital-acquired infections. It was a national scheme. It ranged from not just working, co-producing this with the Design Council, but also being innovative in our procurement of gels, stimulating the life sciences industry, and also a significant interventions as far as education and training of staff. Impact of design in the A&E department, impact of design in the outpatient department. As you can see from this slide, and changes of design and certainly making information available to the patients in the outpatient department. 88% of the patients felt that the guidance solutions clarified the different processes in the A&E department, and that dramatically improved their satisfaction. Very, very different. I'll come back to the target that we introduced in their year 2001, 2002, where no patient should wait more than 4 hours in the A&E department. 75% of the patients said that the improved signage reduced their frustration during the waiting times, and knowing exactly when is their turn, so on and so forth. Technology has also and will have significant impact in probably some of the most important safety traps at the moment that is challenging our healthcare system related to the working time directives. I'm not entirely sure, your junior doctors or your senior doctors, what is the working time directive in Hong Kong, but certainly in the UK it's 48 hours. It's actually as bad as I have to make sure that my residents are put to bed before I leave the hospital. That is the culture, that is where we are in relation to the European working time directive. And that is leading to a significant challenge in really recognizing the deteriorating patient, communicating that between different teams during a handover, responding to a deteriorating patient. And if you really look at the case note reviews, certainly over the last 3 or 4 years, the big challenges happening in the hospital setting is related to the recognition and also the handover between different teams. The ability to use different apps, different information technology tools in really overcoming this handover issue, or being, instead of handing over pieces of paper, which is what's happening at the moment, between different surgical teams. Now, moving on into education and training, and you probably do know, I've presented in Hong Kong numerous times in the past, my own personal interest in the use of simulation. Ultimately, if you don't have a competent staff, they will not recognize the error or the harm, but actually being unable to do something about it. And we know, and the evidence is out there, that the use of simulation could significantly enhance the learning curve and significantly reduce the cost of training a doctor or a nurse, whether that happens to be in a residency program or outside, as far as your continual professional development. And there's a wide range of simulators, from very high-fidelity simulators at a significant cost to very small and cheap inanimate simulations. And thankfully, most hospitals, and certainly I know in Hong Kong, where I was involved with the opening of the Jockey Club training center in one of the universities here, has had a significant impact. We're talking now about patient-specific simulations. That's where we are. We're not really talking about tying knots. This is a patient who's undergoing a carotid artery angioplasty and possible stent. We now can get the MRI or the CT scan of these patients, reconstruct that patient-specific anatomy, and get that same surgeon to work in a virtual environment to do that procedure again, again, and again, until he or she gets into the real operating theater. And not only we're reducing the actual harm and the error, we're also, in many ways, predicting the outcome of that specific intervention. And you can see the impact of that. Overall change of tools in doing an angioplasty and a stent. In those, you can see the number of tool changes seen in green. This is all as a result of simulation, which if we didn't have, it would have happened in real life. And you can see the disadvantages of that in terms of changes in the angles of the fluoroscopy. 42% of the interventionalists changed the catheter during that simulation phase to obtain the best catheter in doing that procedure. Moving on into governance, audit, information, and data. And we're living at this very rich phase of information and health systems, but another paradox. With all the data we have, we seem to be using data less and less and less. And that is another major challenge facing us. In the UK, we've had 10 years of using data in performance enhancement, and I know there are some non-clinical leaders in this room from the UK who remember the days of the KPIs, and so, which is the most dreaded word I've ever heard, or targets. And you could see why targets are introduced. It's not just in the health system, in the university as well. In a university like mine, we now have to publish the minimum of 4 papers in the cycle of the RAE. No one is talking about the quality of these papers. It's the numbers you publish. And this was no different post the NHS plan, which was done for the most honorable reasons. Patients don't want to wait in the A&E department. A target was introduced, 4-hour wait, or a 2-hour access to cancer. What happens in these situations? In many, many ways, there is an increased dissatisfaction with the service. There's a political knee-jerk reaction. Targets are set. They are integrated very much within the performance management. Professionals feel very mistrusted. There is that balance of professional freedom with these very important, in many ways, process targets that are introduced. But for some reason in this new world, the target, which is a mean to achieve a better end, it becomes the end. And if you don't keep pinching yourself why we're doing this, these are process issues to improve outcome. They should never be the outcome themselves. And that, in many ways, you can see a wonderful, dramatic improvement in our waiting times in the A&E department of 98% of patients in the UK do not wait more than are treated with less than 4 hours. That's perfectly okay. But once that 4 hours finishes, if you really took at the patient satisfaction, what they did after they were discharged, waiting their medication, the number of medication errors that resulted on the back of that is significant, and it needs to be looked at. So one of the areas that I had the privilege to contribute to was high quality care for all, working with many people within the NHS, is defining what we mean by quality. One of the advantages of our health system, the National Health Service, is we are a national system. We can have national standards. We could have evidence-based standards. We certainly could have indicators that we can measure against these national standards. And these standards should not be different in Birmingham versus London. We also introduced the concept of making this data transparent and available to the consumer of the service. But the challenge with that, how do you make such information digestible? And then how do you reward quality instead of what historically we did, which is rewarding failure as far as the financial well-being of an organization is concerned. And now we have a number of different outputs from HSMR, which in my view is an interesting tool. Probably is a thermometer that tells you someone has a fever but doesn't tell you what the fever is from. Certainly the rates of harm, infections, lengths of stay, so on and so forth. But specifically I want to finish off to talk about the NRLS, which is the National Reporting and Learning System, which was introduced in the UK more than a decade ago. And it was very much a system that encouraged voluntary reporting of errors. And in many ways, this wasn't based on performance management regime. It was based about voluntary reporting. What could we learn from these reports, and how could we introduce interventions to help us through these? And in many ways, you can see some interesting data. You certainly could go as a provider into the system and look at your own organization and compare yourself to a number of acute specialist organizations. This is my own organization here. As you can see where we are in terms of medical devices here, 5.3% in contrast to the national average. And there's a lot of learning here. The challenge with this at the moment, and this is where you get the political skewing, when reporting of patient safety becomes a performance management tool. So if I could give you one advice, you could certainly look at qualities and outcomes. Safety, never events might be an issue you look at a bit more carefully, but this should never be a tool in which you assess the performance of an organization. Finishing off with one final slide, and that was a recent piece of work we did, which is ultimately listen to the customer, listen to the patient. And this was a recent study where we looked at the correlation between patient experience and patient satisfaction with the top 5 indicators of performance, ranging from HSMR, hospital-acquired infections. And believe it or not, it's the most positive correlation that we've ever seen. So forget about measuring any information, just measure one, and that is the patient. So thank you for the opportunity, but I just want to finish off one small little video, because ultimately we all forget that in the healthcare system we're living in, the patient is a co-producer of healthcare. This is a small little video we did nearly a decade ago, sadly again back to the problem of adoption, in which, I remember this in NHS Plan, our Secretary of State then was Alan Milburn, who decided that every bed should have a television screen for that patient. For all sorts of reasons, we decided to put this video in, very much based on the principle is no one gets off in a plane and takes off without actually looking at the safety video. So I'm going to play you this little video that we produced with patients.
And welcome to the hospital. I'm Nurse Nathan, and this is Terry.
Hello.
While you're here, we don't want you to worry and to feel you just have to lie there and let it all happen. The way we see it, you're an important member of the team taking care of you. So relax, while I and some of my colleagues tell you the 4 ways you can help with your own well-being. Starting with...
Number 1.
Yes, thank you, Terry. Number 1, participate. Always remember you're at the centre of the healthcare team looking after you. So it makes sense for you to be an active member of the team. For instance, feel free to ask your doctor questions and discuss your treatment with him. Or her. Half of our doctors are women, as a matter of fact.
It's a fairly long video. It's on YouTube, but one of the things we taught most of our patients is any doctor or nurse who comes and sees them now, they have to demonstrate in front of the patient that they've used the gel. So it doesn't matter anymore if they're outside, which is very, very irritating, I could tell you, when it first started. But subsequently, it's become normal behavior. So on that note, thank you again for having me. I very much hope I shared with you some of my thoughts.
Thank you, Ara, for a very scintillating lecture. I think all our colleagues in XJ, particularly the people in the head office and the senior executives, are well aware of these problems. I'm sure you have some questions to ask Lord Darcy about his experience, or perhaps comment from your experience. So if you come to there are 2 microphones, and please state your name and whether you're a doctor, nurse, allied health worker, and if you want to, your institution. Yes. Are there any? Yes, Derek.
Thank you, Lord Darcy, for the lecture. I'm Derek Lau from the Quality and Safety Division of the head office. The question is related to the decline of MRSA bacteremia rate in UK that you have achieved. Reading this achievement from Hong Kong, I seem to have heard 2 different interpretations of the understanding of what lessons actually can we learn from the UK experience. On the one hand, people told me that really the critical success factor is in publishing all the data to the public. It's a sort of shame approach, put the units which are performing poorly into shame. And then the other sort of perspective is that really it's the result of a sustained learning experience through the whole system with innovations, some of which you mentioned in the lecture. So from your point of view, how actually did that happen in UK, and what's the lesson for Hong Kong?
Well, I think, to be honest, I think the media pressure, the transparency, once the media got their teeth into this, it became a significant political issue. And when it becomes a significant political issue, politicians do intervene. And it became very much a top-down approach to make the change happen. Saying that, though, there was a lot of buy-in at a local level to many of the interventions, and most of them were evidence-based. There was ownership at a board level, there was ownership at a ward level, and we can very gently see the impact of that. There were certain interventions which were not evidence-based, which did wind up many clinicians. I think the one fundamental one was bare below the elbow. You've heard of that term? I don't know whether you use that here. There is no evidence base that if you are bare below the elbow, the hospital-acquired infection rates will reduce. It's to do with washing your hands below the elbow. And so the answer is there was certainly name and shame. I mean, the media did that. And the data was very transparent and very open. It was performance managed. And that's the type of thing, to be honest, I support. It's a quality, very, MRSA bacteremia, it's a quality, it's an outcome issue with a significant cost. That's perfectly reasonable to have that open and transparent system.
Thank you.
Any other questions or comment? Yes, SV.